Yes, I think, again, I think that we're witnessing a very exciting area in hematology because, we're talking about, as I would say, one is targeted treatment with the TKI, tyrosine kinase inhibitor, whether it's imatinib, dasatinib, ponatinib, nilotinib, but this targeted treatment. Lesson came from CML, expanded to Philadelphia. Then we talked about blinatumomab, proof of evidence that immunotherapy can work. That's immunotherapy. And putting together the two, we may manage to control many patients without chemotherapy. So I think the area of always more targeted treatment is increasing, but there are many other examples in hematology. Just to remind our audience, the first lesson came from acute promyelocytic leukemia in history, and that was the first targeted treatment in oncology, in fact. In a leukemia where there was a genetic marker identified many years ago, and many patients can be cured without chemotherapy. So we have an example of that. Then CML came on the scene, tyrosine kinase inhibitors, and then Philadelphia. So I think there are many examples and more we could discuss now. So I think we're tying together targeted treatment, minimum residual disease monitoring, which in ALL is available for all patients, but in many other diseases, CLL, myeloma can be monitored, lymphoma too, some milder leukemia. So immunology is incorporated, and targeted treatment, MRD, all work together. We have to get rid of the disease. CAR-T is another step forward. There's a lot of hype on CAR-T, many sessions here, many obviously, because there's been a lot of excitement, maybe even too much because of the cost of these and the non-wide availability of these procedures. But it is a major step forward, there's no doubt about it. Another form of immunotherapy through genetically modified T cells of the patient that then are given back to the patient can recognize residual neoplastic cells. This is still at the early days of this because it'll develop very rapidly, but it's another step forward in the same direction. And I think I would finish by reminding ourselves that after all, the last Nobel Prize for medicine was given for immunology in general and immunotherapy, checkpoint inhibitors. So that is the field. So I think it's not just expectation. Now we're actually going into, so putting together very more refined definition of patients, genetic markers, genetic targeted treatment, minimal residual immunotherapy. For many conditions, I think the situation is very positively changing. So we have to be optimistic. And final point, if you're using targeted treatment, this can be given to patients of all ages. We couldn't give heavy chemo to an 80-year-old. This is impossible, even a 70 maybe. Now, if it's more targeted treatment, this is changing, so we can treat elderly patients. Since we are an aging population in the world, life expectancy is increasing always more. This is a key point. If I have to make one final thought, obviously my concern and worry is that the world is very vast. We are talking of lucky few, expensive, difficult, availability, accessibility. So most of the world does not access all this. So this is a worry that we all have, but we can't go ahead with academic help. We go forward. We have to keep an eye on what the real life is and try to help at different levels.